All right, good afternoon, everybody, and welcome to our third healthcare forum for the health system. I think we've got a really wonderful lineup today. We're going to hear from folks from our urology division as well as from our cancer center. Let's see here. So I just want to remind everybody what this forum is about. It's open to everyone in the health system, both our community providers, our employed providers, as well as our administrative staff to help support clinical care and our knowledge of the services that are provided in our health system. We do these forums about 2 to 3 times a year, and we try and do them at lunch and after work to make it convenient for you. And they're also recorded if you have coworkers that are unable to hear these presentations while they're live. And again, trying to just advance our knowledge of the services. We've got some really interesting things you're going to hear today, both from the Cancer Center and urology. Just for some housekeeping, if you could send all of your questions through the Q&A, we will answer all the questions at the end of the presentation. And as I said before, we will share the slides with all of the invitees. For a second. The mouse isn't working for me. All right, so we're going to start out with Dr. Bayliss from the Cancer Center and Infusion Services, and then you're going to hear from 3 of our urology providers, Dr. St. Clair, Dr. Ogiste, and Dr. Brothers. And at the end, I will come up for any questions or answers that you may have. So I'd like to start out by welcoming Dr. Bayliss, and I'll just go through a few bios of our 4 providers first. Dr. Bayliss is actually a Berkshire County native, went to Williams College and received his medical degree at Albany Medical and completed his residency and his fellowship in hematology oncology at Dartmouth-Hitchcock Medical Center up in New Hampshire. He's board certified in internal medicine, oncology, and hematology, and he is our medical director of the Cancer Center and the director of integrative health at the Cancer Center as well. Dr. St. Clair in urology, he received his BA from Williams College and graduated from George Washington University Medical School. He completed a urology residency at Wilford Hall from the U.S. Air Force Medical Center, and Dr. St. Clair is board certified in urology. He has been practicing in the Berkshire since 1993 and is an employee of BHS since 2005. And we promised him if he joined us, we'd get him 6 urologists. And this is the first time we've been able to pull that off. So it feels good to be able to finally fulfill that promise. Dr. Jason Ogiste is from urology. He has already participated in one of these forums with us. I want to welcome him again. He studied at University of Rochester School of Medicine and Dentistry. He completed his residency at Columbia University College of Physicians and Surgeons. He was fellowship trained at Columbia Presbyterian Medical Center, and his specialty is urological surgery. And Dr. Aaron Brothers just joined us this summer. He received his medical degree from Tufts University School of Medicine. He completed his surgical internship at Walter Reed Army Medical Center and his urology residency at Walter Reed National Military Center. And he has received extensive training in robotic surgery. And Dr. Brothers is board certified in urological surgery. I just want to welcome here. He trusted us a lot because the military wouldn't let him off base, as I recall. And so we did the whole interview via Zoom, and his wife came to make sure the Berkshires was an okay place to live. So we're thrilled to have you here. So with that, I'd like to turn it over to Dr. Bayliss to give us an update on the Cancer Center.
Thank you very much, Darlene. Jump right into our slides here. The Cancer Center was opened in 2013 as the local private practice joined the health system to offer a comprehensive cancer care in the Berkshires. We have a beautiful site that many of you may have been over to at the old mansion in the former Hillcrest Hospital. At the Cancer Center, our goal is to provide integrated whole person care, clinically excellent care. We like to think that when a patient comes in the doors of the Cancer Center that they are, they come in terrified after a cancer diagnosis and they are immediately embraced when they walk in those doors, and not just with an immediate plan for their cancer, but care for the whole person. And I hope that this presentation touches a little bit on that. We have a very comprehensive team over there of physicians, nurse practitioners, incredible nurses, incredible support staff, care navigators. You're going to hear a little bit more about that in my coming slides. Our nurse practitioners are vital to our services over there. They provide chemotherapy education for our patients, other treatment educations. They take a lot of our sick add-on patients that need to be seen. They're incredibly helpful to the care of the patients over there. The nurses do upstairs on the 4th floor infusion area, do an incredible amount of actual clinical care and answering triage calls for us, taking care of patients at the bedside, and are hugely important to what we do. Of course, all of our other administrators really make the wheels turn over there. And it's really, you know, we have this beautiful site over there that, but it's really the people inside the building that make it special. Just a little bit more about our whole person care over there. We're very proud of our integrative oncology program. It really kind of brings the whole patient into the picture. We have support groups, educational programs. We have financial assistance for patients, oncology social work, nutrition. I think some more of this is going to be touched on our next slide. But this is just a picture of our integrated health team, our exercise trainer, our social worker, our nutritionist, our acupuncturist, and our person that does intuitive painting with our patients. Again, our integrative health programs are robust. They are all evidence-based programs. We have made that a commitment at the Cancer Center that we would offer integrated health programs that are evidence-based. We use the Society of Integrative Oncology guidelines for evidence-based supportive care. Again, it includes acupuncture, yoga, we have exercise, we have the intuitive painting I mentioned, nutrition programs, and a variety of others. We have two more formal programs that I really like to highlight, because it's one thing to offer these things. They're there as sort of menu choices for patients that know what they want, but we like to take that patient that may feel lost and may not know how they can move forward after a cancer diagnosis, and really bring them in a group setting when we can, when COVID allows, to really give them a plan for how they can rebuild, how they can become strong again, how they can become healthy again. These have been very well received. We have the Moving Forward program, which really offers tools for everyday living. That includes instruction on exercise, emotional health, nutrition, integrative health, everyday living, basically. We were able to collect some data from that program and present that in a poster at the Society of Integrative Oncology annual meeting a couple years back, and it was very well received. We also have our newer program is the Living Well program. This is a slightly different program that really focuses on goal setting and really addressing barriers. We don't focus on weight in this program, but it is really geared towards helping people lose weight, or in some cases to gain weight after going through cancer treatment. And so really gets into more the nuts and bolts of exercise and nutrition and meal preparation and all these things that that patients are looking for. Definitely in this talk, want to highlight another thing that we are extremely proud of, and that's our collaborative with Dana-Farber. For those that don't know, we were the first member of Dana-Farber's collaborative. There are now a variety of other smaller regional cancer centers that are collaborated with Dana-Farber. But we were the first, and we take a lot of pride in that. Collaboration really is a testament to the excellence of care that we provide. Dana-Farber really vets every organization that comes into the collaboration. They do a yearly review. A lot of really wonderful opportunities come from that collaboration, both for the providers over at the Cancer Center for education through Dana-Farber, for closer collaboration with physicians at Dana-Farber, for more expeditious second opinions. During COVID, we really had a nice program for virtual second opinions, which is still running. And then more recently, participation in a variety of Dana-Farber clinical trials. Not every trial, but we have a few selected trials that we feel benefit our patients, and we try to have some of those open here in addition to the other clinical trials that we have open. We have a long history at the Cancer Center of clinical trials. Just to elaborate on that, going back way back to the private practice, one of the original members of the cooperative groups. So we've been doing clinical trials for a long time and have a wonderful clinical trials staff over at the Cancer Center that makes the job for the physicians very easy. We have a couple of accreditations that we are very proud of, and it's incredible the amount of work that the staff at the Cancer Center goes through to make sure that we meet these each year. And Care Navigation, Kathy Hart, who heads up our Care Navigation, does incredible work to get this ready amongst other people. But we have accreditation through the Commission on Cancer and also the NABPC. And these just are another nice feather in our cap in terms of the quality care that we're offering. And these really also are a testament to the collaboration with our other specialists that we work with. I think we do a wonderful job. That's one place where we are very nimble as a smaller organization to be able to work with our colleagues in other disciplines, including urology. We have our tumor board, our monthly tumor board with urology for prostate cancer, our weekly tumor board for breast cancer, and our weekly general cancer tumor board. So we do a lot of collaboration with our colleagues that way. Our visits, we're very busy at the Cancer Center, and I won't belabor this slide, but it's just pointing out that we do see a lot of patients. In this year to date, we're averaging 1,600 visits per month, on track for almost 20,000 for the year. And we do seem to increase that number somehow every year, just a little bit. The infusion room upstairs is the same story, very busy. The nurses do an incredible job up there, as I mentioned before. It's not just a room where patients come and get their infusion. It's a room where patients come and get support, and they finish treatment and they want to come back and see their nurses. The nurses know their whole life story, and it's really a healing place up there. But they are very busy, and those infusions have increased steadily over the years as well. Just a mention of the patient portal. We now, we have more and more patients utilizing that. I think ultimately it is a very good thing. They're getting their path reports, they're getting their imaging. We had to get up to speed with some of our processes over at the Cancer Center for this, but I think we've been doing so, and patients really like this feature. We are about to join the rest of the health system. I want to point this out because previously we've always been trying to do better with communication. I think this is going to be a really good step. We're getting on to the ambulatory Meditech starting Monday, that I think most of the rest of the health system utilizes. And I think that's going to be a really nice change, and hopefully improve even more the communication and flow of our records and our communication with the rest of the docs. It will offer a few things that are mentioned on the slide, including survivorship and staging, which I think is going to be helpful with a staging system built right into the EHR. So a stage of the cancer patients will be easily accessible. Let's see. So just a couple of nuts and bolts, how to reach the Cancer Center. As of up to this date, we are faxed referrals. Is that changing on Monday? So I see a yes and a no. Okay, so I believe that as we go to ambulatory on Monday, we will start receiving ambulatory referrals. If we need to clarify that with the community, we can do that, but I think that's going to be helpful. We have a general office number that's listed there. We have a quality measure to see oncology patients within 7 days of their referral. And I think we do a very good job with that quality measure. We also have we try to see hematology patients within 14 days. Okay, thank you very much.
Hi, everybody. Thanks for inviting us, and thanks for your nice introductions, Darlene. I want to start by just going through the providers. We have some additions, as Darlene said, we got to 6, plus we have a couple PAs. Joe Yard's been with us for 5 years, and Kevin Colleen's been with us for more than 10. Kevin's now working. I learned to live with this thing. Kevin's now working 3 days a week in the Great Barrington office and providing our service down there. Jason, you'll meet in a little bit. Oh. Along with Aaron, you'll meet in a little bit. Sam Litvin, who does go by Sam, is on vacation this week, so he is missing being here to meet everyone in person. But he came to us in March and is doing general urology here in Pittsfield and very busy already. And then our 2 PAs, Elena and Lorianne, really make us able to function with on our inpatient consult service, which is quite busy, and we're trying to manage both our hospital patients and our inpatient consults at the same time, and we couldn't do it without them. But we have a team that is very committed, and a lot of people that keep our office running. And that includes 3 nurses who do our intravesical therapy for bladder cancer treatments, manage a very busy catheter service. We try to get visiting nurses and other outside staff to help with routine catheter changes, but it's a very busy catheter service, and do our percutaneous tibial nerve stimulations and triage our patients, along with now 3 ultrasound techs who, so we can offer in-office ultrasound and look for stones or other abnormalities without having to wait for scheduling and radiology. And along with a very big staff to manage front office functions and patient consults, etc. These are the same questions that Trevor just went through. To reach us, that's our main number. And you can schedule patients for all 3 offices through that number. We despite being at 6 providers, are still very backed up, unfortunately, to the point that we are having to triage all of our new patient consults to try to make sure we see the urgent patients as soon as possible. And unfortunately, some of the vasectomies or other not as urgent consults can wait as long as 3 months. As part of trying to improve our patient flow, we are going to be working a little bit towards trying to transition patients who we know really who have been stable for quite some time and don't need any active urologic care back to their primaries. These guys that we've been following for their prostate cancer for 10 years, and we tell them they're cured, they don't need to see us anymore. It's a little hard to get them to do that, but we'd like to make sure that as we try to do that, that we give the primaries adequate information to transition whatever urologic issues are stable, but we're asking them to manage. So we'll be sending them copies of the note along with the task for anything that special that they might need to do. And obviously, if something new and active comes up, we'll be available to see them.
So thank you, Steve. And thanks to Jen and Kathy and Darlene for putting this together. I think it's really a wonderful forum for us to now highlight some of the new initiatives that we have ongoing in the urology division. So just a little background and context for the Zoom audience. Although my practice is primarily grounded in general urology, over the past years as it's evolved, I've developed sort of a focus primarily on benign, symptom-driven, quality of life-driven urologic conditions. And I like to categorize those into two groups, men's health on the one hand and female urology on the other hand. But because of our time constraints today, I'll try to focus primarily on the men's health segment. And I guess during next week's forum, talk a little bit more about the highlights in terms of what we're offering on the female urology side in our division. So over the past decade or so, there's been a significant shift in terms of exciting technology being introduced into urology, especially in the men's health section. BPH in particular is what I'll focus on today. The paradigm for management have really shifted to more minimally invasive therapies, ones that are safe and outpatient based compared to our gold standard in the past, transurethral resection of the prostate, for example, or open prostatectomy. So one of those new services or service lines that we're offering our division now is this Resume RFA procedure, or radiofrequency ablation of the prostate, which works by converting sterile water into steam or water vapor, which when injected into the prostatic tissue induces shrinkage through what we call apoptosis or programmed cell death. And over time, as you can see here, you can see the before picture, the during, and then after. You can see that the prostatic urethra is now open compared to the before picture where it's pretty narrow. That change can take up to 2 months to really start showing and for symptom improvement. Another such procedure, which I don't have a slide on, is the prostatic urethral lift procedure, or pull or urolift procedure, which is one that is similar in terms of its how it works for prostate with enlarged prostate and symptoms. And as its name suggests, it basically pulls the prostate, the enlarged prostate, away from the lumen of the prostatic urethra and the bladder neck, allowing for relief of obstruction or lower urinary tract symptoms in these men. So over the past few years, what we know is the FDA has approved these. We have data backing these interventions, intermediate data now, 7 to 10 years data showing their efficacy and durability for the most part, and their safety profile. And we are in the process of adopting the prostatic urethral lift procedure for our division, and we'll have them both available and accessible for our patients here at BHS. As you might expect, we also have a strong collaboration with radiation oncology, and over the past 9 months or so since my arrival with Dr. Clair and Dr. Jabara, we've been able to get the SpaceOAR hydrogel implant program up and running. And for the staff and listening audience who might not be familiar, so the OAR and the SpaceOAR is organ at risk. And the organ at risk in this scenario is the rectum when patients are men receiving radiation therapy for their prostate cancer. To reduce rectal toxicity, this implant device is absorbable. It's made of polyethylene glycol, and it's injected between the space between the rectum and the prostate to lift the prostate away from the rectum, allowing for protection of scatter and toxicity from the patient's radiation. So I just want to summarize, and we do have limited time. I want to summarize by saying over the years, I guess, the patients here in the Berkshires would have to go to tertiary care centers in Boston or to Albany or New York City for a lot of these minimally invasive proven services for their care. But now we have them readily available here in our division. We have the talent, we have the staff, and we welcome the referrals of these patients who might be interested in these services to our practice. We'll be happy to accommodate them. I don't think I have enough time to really go into these future initiatives, but at least, you know, that's sort of our bigger goals here as part of the division, and with time to build a Center of Excellence for Men's Health in collaboration with our other services within our facility, as well as one for the Center for Female Urology and Incontinence Management for our female patients who might have urinary concerns as well that need to be managed. And we'll save this for another date. So thank you again. So I welcome Dr. Brothers.
All right, well, thank you for the kind introductions. I just joined right at the end of June. I finally got up here. The military would not let me travel in March of 2020 to interview. But I met my wife online, so I figured I could pick out a job online. You know, how hard could that be? But, you know, I think they took a risk on me, and you know, she came up and said, "It looks great, let's go." And I mean, she's the boss. So, but I did train in the military and did receive an extensive amount of training in robotics. I didn't know it was extensive until I came out of residency, went to my first duty station. And my two partners were, you know, maybe 5 and 8 years ahead of me. And they said, "Oh, we're doing a prostate on Thursday." And, "Oh, cool, I'll come." And they said, "Yeah, we're doing an open." I said, "Wow, I've never seen one of those." And I think, you know, Dr. St. Clair and Dr. Ogiste, and that's probably almost unheard of coming out of residency and having never experienced, you know, an open radical prostatectomy. But that's just the way it was when I started in 2010 through 16. Almost all pelvic work urologically can now be done safely robotically, and if that's how you train, that's how you're gonna usually do it. And so I continued that at my duty station down in Georgia. The volume was enough to persist, and now excited to be somewhere where we can really kind of increase that volume and then start bringing more complexity, I think, back into our system and not having to send everyone out far away. This is just an example of our DaVinci system, and we do have the newer technology here, the XI system, which I had not got to use because the military wouldn't pay for it at our facility until I got here. So very excited to be using that. It's way easier to set up and use. So, you know, we're doing all sorts of pelvic work robotically. We do our partials, even our radicals are robotically, and reimplants, ureteral work, and even some of our bladder stones and other issues. We do still do a few open procedures from time to time. And I don't think that's going to go all the way away, but you know, the advantages of the robotic surgery, people always talk about smaller incisions and maybe quicker healing. You get out of the hospital faster. I think it depends on what meta-analysis you look at. You could weigh it one way or the other. We definitely usually see a reduced amount of blood loss robotically when we're operating on, especially the prostate, just because of that insufflation in the belly. Usually kind of cut the EBL maybe by half, and with the partial nephrectomies, assuming that you can keep tempo and not slow down. For me, I definitely like it. The magnification is great. I grew up playing video games. I tell people I've been practicing for this my entire life. And you know, when I have to do open surgery, it's you know, it's almost like I got to pretend like I'm the robot. And of course, patient perception is that it's cutting edge, it's the newest technology, and they want it, right? And as long as it's not worse for them, and it's not, then I think it's appropriate. I don't think we'll be doing any vasectomy reversals robotically soon, but that's one thing that a few people were trying to fill time with at other facilities I've been at. Of course, there are some costs and other issues that we work out. But as we build the volume back up at this facility, we're going to get those times further and further down. And I think it will come out very similar to our open procedures. So we're happy to have this back in house, and then happy to see any referrals or patients to talk to them about whether they may or may not be candidates. There are some issues in terms of positioning and body habitus that we do have to deal with, and we look forward to taking care of everyone robotically if we can.
Thank you, everybody. I just want to go over some of the questions that we may have from anybody. I don't know if there's any that have been posted here. Are you seeing any? Okay. Oh, here's one. On the resume, how long does it take, Dr. Ogiste, for the improvement in symptoms? You can go back up.
So it's so variable. A lot of it has to do with the size treated. The FDA approved criteria is prostate size between 40 and 80 grams. A lot of it has to do with the anatomy. What I find so far in my practice since I've been using this particular procedure is that the patient with a larger prostate tend to take longer to respond. But in terms of the normal, 40 to 60 grams, say between 2 and 3 months for full efficacy. But a lot of patients will see some improvement, usually at about a month or so, in starting relief of their symptoms. Mm-hmm.
All right. I think the next question we have is, so I'll take from any of the urologists. With prostate enlargement, is there a non-surgical approach to management? Who wants to take that one? Do that one, Steve?
So I can take us back a long ways, but in the 1980s and 90s, the second most common operation in the country other than cataracts was TURP. And that's when the medications for BPH were just starting to come out. And there was a big swing that a lot of people were managed for years. And I still have a cadre of probably several hundred patients who are on finasteride and or an alpha blocker. And a lot of them can be managed well and their symptoms are controlled and they don't go into retention or have other complications. I think that arrow kind of swung too far away from mechanically fixing the underlying problem. And these newer modalities, new modalities have come along and come and gone for the last 30 years. And a lot of them were good short-term and didn't work long-term. But the two that Jason talked about have been out for 5 to 10 years and it looks like are going to be beneficial. But there certainly are medications that help, and not everyone needs a procedure or an operation.
So the point is, come see one of you and you'll make that decision on how to medically manage that situation. Perfect. Okay. The next thing I wanted to talk about was in the Cancer Center for Dr. Bayliss then. A couple of questions here. First one is, when does the navigation team get involved in care? And the second is, how is the care coordinated with the Dana-Farber Cancer Institute? So while you're up here, you can answer both questions. Thanks.
So the first question, as I mentioned, I think before, care navigation is crucial. And actually, our care navigators are sometimes the first person that the patient hears from after their cancer diagnosis. So they get involved immediately. When patients come in for their initial consultation at the cancer center, they actually meet with the care navigator downstairs before they even come up and meet with the physician. The care navigator will then come up to us and give us some background info and fill us in on some barriers that might be there, whatever they may be. Let us know what the patient is even nervous about coming in. So they get right involved right from the beginning of the care. And then they are crucial. They're really, patients find it really helpful to have that person that they've connected with right from the beginning. They're seeing a surgeon, they're seeing a radiation doctor, they're seeing us. They're overwhelmed very quickly, and they know that there's that person that was so friendly and nice with them when they first came in. Hopefully everybody was, but they remember that care navigator, and they have their card and they know that number, and it's a really nice point person to guide them through the process. So hopefully that answers the question. There's a lot that could be said about care navigation, and then the Dana-Farber collaborate. So I think the question was more so about collaborating care. What we have been working on with Dana-Farber, I think I mentioned in the talk, the expedited referrals. Being that we're in the collaboration, those referrals are expedited for us, which is really nice. The use of virtual during the COVID pandemic, which is still occurring, which is very, very convenient for our patients. That many of them would not even go for a consultation, to be honest with you, in Boston if they had to drive into the city. So that's another feature that we've really rolled out with Dana-Farber. And then just the collaboration with the physicians. Pre-COVID, we had this once a year education session where we went in person to Dana-Farber and got lectures from the docs there and really did some sort of networking and sort of getting to know face-to-face. And hopefully that will resume post-COVID. I think it's going to be virtual maybe this year. But just so that collaboration where we really get to know those physicians well has really helped. I have most of these docs' cell phone numbers, and we text back and forth. Can you give a call on this patient? Blah, blah, blah. So I think those are the ways that it has really benefited us in terms of patient care. Hopefully that answers the question. If there's anything specific, I'm happy to talk about.
Thank you. We'll just go to the podium here. Okay, so I think that's all we had for questions today. I want to thank you all for giving us some of your precious time in your busy day. We do want to hear from you. If you have any other questions that you think of, please either email them to Kathy Amuso at the email address here, or give her a call at this phone number, and ask that you watch your inbox for the next forum that we'll have in the next few months. So thank you very much for your time. Have a good day.